groups of bereaved suicide and another cause of death. And the third paper of this study was concerned whether perceived stigma following sudden bereavement is associated with suicidal behavior.
This context, her work focuses on stigma, and she has worked a lot, in fact, on stigma associated with mental health problems among children and adolescents living with HIV in Africa. And here is some of the research she's going to present us. Welcome.
Thank you. Thank you everyone for the invitation, and I'm really excited to be here. It's been a great day yesterday, and I'm looking forward to another full and enriching day today. So I'm going to talk about a little bit about the research that I've been doing in Uganda. So to the gentleman that was sitting there talking about sub-Saharan Africa for a little bit. For those of you, oh, the font has gone funny, but for those of you who might kind of nod off in the middle, I want to start off with the main messages. So I think really important to think about is that HIV is really impacted by mental health. So that's point number one. Number two is that the stigma associated with mental health problems can prevent young people and their families from actually seeking out and receiving treatments. And then finally, is that we really need both culturally and contextually relevant interventions to be incorporated into existing care pathways. So the main message here is really that we can't think about silos. Symptoms starting before the age of 14, 75% report those problems starting before the age of 24. So if we're thinking about this as a really vulnerable time, it's no wonder that also on top of that experiencing HIV, the community at large, not just around healthcare workers or lay healthcare workers, but actually thinking about community members, people in the symposium in the afternoon. So you might want to be around for that, and you can. I'll talk about the different steps and what we do.
Thank you so much. Are there any more questions?
The question is for Dr. Brownhill. You mentioned earlier that after implementing the anti-stigma schemes, after starting to see results, the lifespan of each of the schemes is kind of short. So my question was, why do you think that these schemes or the anti-stigma have an expiration date, if we can say, and what do you think should be done to avoid such things?
Great. Thanks for that question. So I think partially it depends on, say for instance, if we're implementing a campaign in a healthcare service or in a school, it might be that the personnel who actually originally received training, they might just be, circulated out of there. So it might be that the initial people who received the intervention just aren't working in that context anymore. It could just simply be down to forgetting as well. Often campaigns are running at quite a short time, so it might be like an afternoon workshop or something like that. So it's not a really long time to kind of take in information. So just in terms of us retaining information better, if we have the capacity to maybe do a follow-up training or a booster training like a couple of months after, just to kind of freshen up those skills and remind everyone of best practices or whatever it might be that campaign's been focused on, or kind of like replaying a message or personal testimony from someone to kind of like reignite those memories and that kind of process of thinking like, oh, that person's not so different to me after all. That's what might be needed. And sometimes I think people's, you learn something and then it just gets buried under everything else that you face.
Before the break, we know that the majority of people who will develop mental health problems will have the first signs they are developing a mental health problem by the age of 16, that will be half of them, and by the age of 24, it will be 75% of them. And when you get to the right treatment, that's despite the efforts of your parents or your own efforts, And often it's because the help that is available, again, as we just used, it doesn't just predict psychotic disorder, so 3 times more likely approximately to have psychotic disorder if you have sexual abuse than if you haven't, but also predicts post-traumatic stress disorder, generalized anxiety disorder, social phobias and panic disorder. Genetic alone is not enough, environment alone is not enough, it's a combination of both that really makes your odds go up. And here you can see the part
that I had was to train a group of raiders, and that occurred in May of 2018. These are the names of the people. They're not set some goals. One of the goals was to have consensus meetings. So there are 2 phases of training. One would be the didactic phase, where we established integrated reliability on the scales that I mentioned. There were some language differences between my work and the work with the raiders. There were also cultural differences. And there are differences among psychiatrists about how they...
Our attention span might not be as good as you think it is. It might be worth asking one question at a time. Don't forget.
First, after detecting ultra-high risk patients, what are we going to do afterwards? And this raises 2 questions. Are we going to stigmatize them with a burden of a disease that is not yet here, and that it would not probably be here? So there are many ethical questions behind. Second, if we are going to treat, you said we are not going to give medications, but we are going to probably propose other psychotherapies or cognitive remediation or even making...
Talking to individuals or families about the fact that they're at risk for psychosis. We're actually not even planning to not even mention that. Really what we want to do is we want to tell them that in psychiatry things have really changed and that we're really focusing on quality of life. And so we want to improve the quality of life or the quality of the health of the individual. So the individuals that come to us, those that I mentioned that met criteria for being at clinical high risk, most of them or all of them were having some trouble in school.
It's from low and middle income settings. As we know, there's not a lot available at the moment. The work is funded by the Medical Research Council in the UK, and it's a 5-year project. We have just started our 2nd year, so things are starting to happen, which is very exciting.
Master thesis, we have lots of posters. When you go to most of the local congresses here in Tunisia, there, at least in the terms in psychiatry or maybe also in preventive medicine, there are quite a few studies, small-scale studies on stigma. However, if you look at the real numbers of publications in the scientific journals, so I found 7 papers concerning multi-site studies, and there was also then shown at the quantitative evaluation, and it has also been shown that there was a decrease in referrals in psychiatry, which I found is very important. And the most of these competencies were also maintained over 18 months. Now I'm going as last example of studies on intervention work that we've conducted with them. In fact, I started in 2009, as I showed you, where we worked together on assessing stigma in depression. And now we moved on to this phase where we're going to develop and pilot interventions. The studies that the next speaker with is Dr. Fatma Shafi. As I told you, she's the head of the local Tunisian suicide and committee on suicide prevention, and she's going to talk on stigma and suicide.
Study shows a high rate of guilt and shame, and elected stigma. It's about, for example, avoidance and suicide, with a double effect. The negative effect was the Werther effect, with imitation suicide cases and increase suicide, complete suicide, and suicide. And suicide is more and more considered by the Tunisian people as a social and mental health problem, and less seen as a sin and loss as a taboo. But unfortunately, we have no study, Tunisian study about stigma and suicide population. It is very important to prevent and to have anti-stigma action.
Merci for this invitation. So thank you. I'm going to give you some of my experience about a few years ago. The stigmatization of mental illness and perception of the psychiatrists in a Tunisian sample of medical doctors, non-psychiatric doctors. What we hypothesis is that there is also a negative impact on the physical health
developed. What is the role of stakeholders? So, kind of a show of hands, who says that stakeholders, so this would be the patients or family members or the service providers themselves, are involved in developing interventions? Okay. By that involvement, what do you mean by involved? What are the things, how are stakeholders usually involved in intervention development? This is like school again. You didn't sign up for this, did you?
I think sometimes the first step is that a parent of the patient is very he felt or she felt the negative impact of the problem on her or his parent. So he tried, for example, to create an NGO, a local national NGO, and try to sensitize different other stakeholders.
So, whoops, did I miss I've missed this slide. That's odd. Okay. That's okay. I can talk about it. So traditionally what happens is that these interventions are developed by experts. So we talked about that. So researchers, by clinicians, from theory. So there's usually some kind of theoretical idea and a conceptual framework. And we say, okay, so this is what goes on, and now we're going to develop an intervention to address X as a way of improving mental health outcomes. Then that is usually taken to a group of people who might somehow be involved as stakeholders and say, how does this work? Or do you like this?
Good evening for all. I think that I will have the most challenging presentation in the conference. First, we are the last to present. Second, we will not talk about mental health. We will talk about HIV. And we will talk after very eminent expert and English fluent speakers. So I will try to be the most brief possible and try to present an original experience for co-development, as Tatiana previously said, co-development of